Hello everyone, I am Dr. Sagar Garg and I am the expert faculty at Dr. Lall's BDS to MDS in Periodontics. So this session is about your upcoming INICET exam, and I will be discussing those topics, those questions that have high probability of being asked in the exam, like for the last minute what all you should be revising and what all chapters you should be looking at. So starting with the first one, it will always be about anatomy of the periodontium. If you people have attended my lectures, I always lay emphasis on gingival epithelium. Gingival epithelium is very, very important. All right. So basal lamina, before that, if you want to look at like circular epithelium, junctional epithelium, and what changes occur in the epithelium, they also are important. But basal lamina specifically becomes all the more important. Its thickness and what it is composed of, lamina lucida, lamina densa. Okay, so basal lamina is very important, and people do mistakes like what is internal basal lamina, what is external basal lamina. So all these questions, especially for INICET, all the tricky questions becomes all the more important, right? Like then about what is absent in junctional epithelium and where is circular epithelium not found, like that, like keratinosomes, they are the modified lysosomes present in stratum spinosum. Langerhans cells, very, very important, they are absent from junctional epithelium. Then all the types of keratins, right? K6, K16, K1, K2, K10, 11, 12, K19, K1, it is present in orthokeratinized, nowhere else. Similarly, K19 present in parakeratinized, but nowhere else. Okay, 6 and 16, 5 and 14, 4 and 13, esophageal type keratins, right? 6 and 16, proliferation specific keratins. Okay, so all these you have to remember, and not just these, what I have put up here for you. Okay, coming back again, gingival fibers, they are important. You have to look for like the mature elastic fibers, elastin fibers, they are present in gingiva, while in PDL the immature forms are present. So you have to segregate the topics where is asked, because when there are confusing things, you cannot do mistakes in the exam. Periodontium, again, cementum, alveolar bone, and periodontal ligament fibers. Theories around the periodontal ligament, everything you have to remember, CEJ, CEDJ, and especially about the CEDJ, what you have to remember, its dimensions, its widths, and CEDJ is the point where your the obturating material must end. Okay, types of CEJ. So Schroeder classification of cementum, very, very important. You have to remember that acellular covers cervical third while cellular covers apical third. Okay, the difference between primary cementum and secondary cementum, or cellular cementum and acellular cementum. Like I said, all the four types of cementum, periodontal fibers. Basically, whenever they ask, they give you confusing options between oblique fibers and alveolar crest fibers. So what is the function of oblique? What is the function of alveolar crest? Apical fibers, interradicular fibers, you cannot do mistakes in that. And again, like I was telling you, in gingiva, the fibers are differently, while in PDL, the principal fibers are type 1 and the reticulum fibers are type 3. Then which elastic fibers are present in periodontal ligament and which elastic fibers are present in gingiva? That also you have to look at. Then bone, alveolar bone. Alveolar bone is very, very important. The structure of alveolar bone, like alveolar bone proper and your supporting alveolar bone, the osteon, what vitamin C is important for, what vitamin D is important for, everything you look for in alveolar bone. All right. So first chapter, very, very important, anatomy of periodontium. You just make your quick points that these are the points that you now remember wholeheartedly, but few points you get confused at, you must mark them and revise just before your exam, because one or two questions will definitely be asked from this chapter. Plaque, another. In classes, we already always discuss that plaque is a very, very important topic, and it's an evergreen topic. You cannot take plaque for granted. Okay, microbial complexes. It's a simple thing, it's a straightforward thing, but yes, we tend to forget at times, and we get confused because the way it has been given in Karenza. But during the classes, I have always tried to explain to you like about aggregative vector AA, where it is found, in which complex it is, its serotypes, okay, its leukotoxins, everything you have to remember. Then which are the primary complexes, which are the secondary complexes, which bacteria are associated with bleeding on probing, which bacteria is associated with pregnancy gingivitis, with puberty, and especially in localized aggressive periodontitis, it is AA. But in generalized aggressive periodontitis, what bacteria are found? Like I told you in the class, everything. So in that, you cannot get confused. In generalized aggressive periodontitis, P. gingivalis, Prevotella intermedia, AA is very less important in generalized aggressive periodontitis. Okay, and do remember Streptococcus constellatus. It is a part of orange complex, not the yellow complex, which is specifically reserved for Streptococcus. Okay, keystone pathogen, Sokorensky's modifications of Koch's postulate, and classification of plaque is important. We do mistakes in this, that what causes root caries, what causes calculus, what causes periodontitis. Okay, so subgingival plaque, one is tooth associated, other is tissue associated. And the bacteriology of plaque, like what dominates at the surface, what dominates in the apical part, where you can find cocci, where you can find rods and filaments, where are they present. Okay, so all those things are important. Quorum sensing, important question from plaque chapter. Co-aggregation, co-adhesion, difference between co-aggregation and co-adhesion, I have explained numerous times during the lectures and during our doubt session also. So that always remains important. Peptide signals, streptococci, AI2, autoinducer 2 by many different bacteria. Corn-cob, test tube brush formation, Corynebacterium metrocoti. Whatever the name is, you just have to remember how it is asked in the exam. All right. Theories, specific plaque hypothesis, non-specific plaque hypothesis, keystone plaque hypothesis, and ecological plaque hypothesis, which was given by Marsh. Plaque, very, very important. Composition of plaque and how it is formed. Pellicle, it comes from the saliva. Remember, okay? So everything is important in plaque. Then if there is plaque, calculus has to be there, right? Crystal forms in calculus, very, very important. What are the crystal forms, in how much concentration they are present, okay, and in which region, which type of calculus dominates. Okay, this is again a straightforward question, but you have to remember, you cannot get confused. So if while revising you find that you have difficulty in remembering that subgingival calculus has same hydroxyapatite like supragingival but more magnesium white locite and less brucite and OCP, then you have to revise it again, that and how phosphorus is more critical than calcium, although calcium is present in much more quantity than phosphorus. Difference between early plaque of heavy calculus and non-calculus formers, right? Then how does calculus formation takes place? The theories, the different theories, what becomes less, what becomes more, how does pH changes, what bacteria help in calculus formation, okay, and what enzymes help in calculus formation. Everything about calculus is important, docs. GCF and saliva. Now, this chapter, this topic is repeated so often that new questions are seldom being asked from this, but it stays important, especially from the saliva, the enzyme systems, which means that your antibacterial factors. Okay, they are very, very important. Lysozyme, lactoperoxidase, thiocyanate, lactoferrin, myeloperoxidase, and how do they work also, right? At which area they cleave, how do they affect the bacterial cell, that also you have to remember, not just the names of the bacteria against which they fight or against which they act, their mechanism you have to remember. And I do not need to tell, IgG with GCF and IgA with saliva, that's as simple as it can get. Then the leukocytes in the sulcus area, that you have to remember, what is the percentage of PMNs and what is the percentage of mononuclear cells. Okay, and what is the ratio of T to B cells? Then the evergreen question, glucose is greater in GCF than that in serum. Proteins are less. Okay, this is very important. Then the methods of collection of saliva, sorry, GCF. Okay, that also you have to remember all the four methods. And please, GCF can be transudate, can be an exudate, but predominantly it is an exudate. That you have to remember, and accordingly, because in INICET you won't get that question like what is GCF? Exudate, transudate, both of the above, none of the above. No, they will ask you a better question in a better way about GCF. All right. Inflammation, gingivitis, what are the diseases concerning the gingiva? That is important, like from the stages of gingivitis to features between a normal gingiva and the gingivitis, gingival enlargement. All these topics around gingiva are important. You can get picture type, I mean image based questions also. Okay, the stages of gingivitis, this chart, this flow chart is very important. You cannot forget this. All right, this is very important. In what stage which cell is predominant, which feature appear, when does bleeding on probing appears, when does changes in the surface texture appears, consistency appears. Okay, and what is the normal consistency, and what happens to the consistency in gingivitis, how does stippling appears. Okay, everything is important in this, right? Gingival enlargement, I told you, the drug induced gingival enlargement, very important, and it is related to the inflammation also. Not every gingival enlargement is non-inflammatory, many are inflammation based. And in which condition all the three types of gingival divisions get affected: marginal, interdental, as well as attached. That again, I know you all would remember this, but it stays important. Remembering that, knowing that is very important. You must not act like where does it has come from. Okay, you all know in what diseases attached gingiva is involved. All right, leukemia, idiopathic, plasma cell gingivitis, all these you have to remember. Features, like I told you, picture based questions can be asked from gingivitis. Bleeding on probing, a very important point. Or gingival bleeding is very important. They can go for systemic questions, I mean systemic related conditions, or what deficiency can cause, what blood disorder can cause gingival bleeding. Okay, so related, you can relate it with oral medicine and your general medicine when this question has to be asked, right? BOP appears earlier than a change in color or other visual signs. Then color change is important. Toxicity, bismuth, arsenic, mercury, lead, Bertonian line, everything is important. Stippling, right? And color change, where does it starts? Stippling, where you can see it, and how does it appears, what happens, and in what age it appears, in what age it is lost. Texture, contour, McCall's festoon, Stillman collapse. It is an evergreen question. It will be asked for sure. Okay. Pockets and bone loss, very important, these chapters. And this, it's not like you can just go about it in a minute. Pocket, bone loss, TFO, they are all concept based questions. Concept based questions are asked in this, so you have to be very sure about what you study and how do you approach the question. About pocket formation, numerous questions can be asked from pocket, right? Especially in what region the pocket formation starts, in what area of the pocket most damaging changes occur, what happens, the mechanism, like where does PMNs reach, where do they increase, how does junctional epithelium detaches from its attachment. Okay, so all that is important. Picture based question will help you, like what differentiates between a suprabony pocket and an infrabony pocket. Okay, that is very important. Then rate of bone loss, that low and stillness study about Sri Lankan tea laborers. They can ask you what is rapid loss, what is moderate loss, and what is like practically no loss. Okay, then the patterns of bone loss, craters, ledges, exostosis, everything, reverse architecture, very important. Okay, so that radius of action, everything important from this. Pockets, very important, guys. you have to do questions on pocket. Again, do many times you do questions on these topics. Like I told, TFO. In TFO especially, what is primary, what is secondary, on that question can be asked. Then what is jiggling trauma and zone of co-destruction. It always stays important and very important. TFO cannot initiate pocket formation. Okay, TFO cannot initiate, it can aggravate. It is the most important aggravating factor for periodontitis. Okay, TFO does not affect marginal gingiva, so TFO does not cause increase in GCF flow. These are the points that you must remember about TFO. The stages of tissue destruction, what happens in injury phase, in remodeling phase, in repair phase, everything you have to remember about TFO. This, what is primary, what is secondary, normal bone, normal periodontium, everything you have to remember. And when it comes to periodontitis, chronic periodontitis, you will be asked simple questions, easy questions. But aggressive periodontitis has a lot of tricky questions. Okay, differentiating between localized aggressive and generalized aggressive, tricky questions can be asked. So you have to remember the difference in features. What are the contrasting features? And guys, please do not forget between the primary characteristics and secondary characteristics of aggressive periodontitis, because I remember during the course of our discussion, doubt solving, you people always ask a question about, sir, this is why it is not a primary characteristic, or why the answer is given like this. Please differentiate between, like, distolabial migration is not a primary characteristic. Okay, they do not appear very important, but subject is healthy and familial aggregation, they are your primary characteristics. Rapid attachment and bone loss is primary characteristic, and that leads to secondary characteristics like distolabial migration. Okay, diastema, spacing, pathological migration, they come under secondary characteristics. Like I was telling you, what bacteria are important in generalized aggressive periodontitis. PG, PITF, TD, your red complex bacteria, right? They are more important in generalized aggressive periodontitis. And the genetics surrounding aggressive periodontitis. Interleukin 1 beta, important. Fc gamma R2 receptors, HLA A9 B15. Everything about aggressive periodontitis. At times I feel like I'm telling you the whole chapter, and within 5 minutes we can cover that 2 to 3 hours topic. But when you are revising, you must know these are the points which I know, but these are the points which I am still confused at, and still you have time and you can sort it out. All right. Diagnostics, not like it's a very vast when you see through in your books, but in your notes, in our lectures, we have discussed what are the important points which can be asked. Probing is very, very important. Around the probing, that level of attachment, and that question in which they give you values that can be asked, so you have to remember that clinical attachment level, and that is the most important criteria to know how the periodontitis is progressing, how the pocket is getting more damaging. Okay, so probing depth, how do you probe, probing force, types of probes, first generation, second generation, automated probe, pressure sensitive probes, everything is important about probing in diagnostics. Then you can see Bana test and everything, radiographic aids you can see. Then your risk factors, prognosis, those chapters are important. Levels of significance, not very, but yes, a bit can be asked from that. Level of significance was simple. 4 levels, what happens, which is tangible and intangible, large and small, so many times we have discussed. But about that risk chapter, what is a risk factor, what is a determinant, okay, what is an indicator, what is a marker, that you must not get confused with. Okay, and what defines a risk factor, and what is the differentiating factor, differential between a risk factor and a risk determinant. Okay, not just like risk factor is this, only tobacco, diabetes, pathogenic bacteria, only this is not sufficient when it comes to INICET. Okay, you must remember what can be called as a risk factor, that the exposure has to be done before the disease onset. It can be identified only through longitudinal studies. Okay, all those tricky points which can miss out, they are important about diagnostics. Then medical conditions, very important when it comes to INICET. Diabetes, you see, you segregate. Diabetes is very important, and blood related disorders, cardiovascular diseases. These three are the most important. Okay, and pregnancy, like that can come in various chapters. Gingival enlargement, it is in gingival inflammation, it is. But surrounding that, what drugs you can give in pregnancy, what you have to avoid, what can cause pregnancy gingivitis, in what trimester you can treat, what happens after pregnancy, all that things surrounding pregnancy you have to remember. Then in hypertensive patients, what anesthesia you can use, what is antibiotic prophylaxis, and what how will you manage if a patient has an episode of something that occurs during your treatment, what drugs you will give, how will you manage. All those things are important. What antibiotic prophylaxis regimen you use, right, while treating an infective endocarditis patient. That is very, very important. Preterm low birth weight, why does it occurs, how it is related to periodontitis, diabetes mellitus. Sixth complication, periodontitis, is how it is related, what happens to AGE in diabetes. All those things are important. Necrotizing infections, from ANUG, primary herpetic gingival stomatitis, in AIDS, linear gingival erythema, difference between NUG, NUP, NUS, all those things are important. The treatment, the disease part, yes, it is important, but the treatment also, like how does primary HSV gets treated, how does ANUG gets treated. Drugs, guys, ANUG, the drug of choice, amoxicillin. But when ANUG is in the setting of AIDS, then metronidazole, right? Mouthwashes, you start with both hydrogen peroxide as well as chlorhexidine. But as the disease goes on, as it is coming towards resolution, you discontinue H2O2 and only chlorhexidine is continued. So that point is very, very important. You cannot mistake in this. Second visit, it after 1 or 2 days of first visit. Third visit is 5 days after second visit. That is important. Acyclovir, how and when you give in primary HSV infection, important, right? Abscess, periodontal abscess, pulpal abscess, pericoronal abscess. What are the differentiating features between abscess? Drug regimen and all treatment, all that is simple. You will do very, very simple. But how can you differentiate between periodontal abscess and periapical abscess? Very important. What has vital pulp, what has not vital pulp, in which abscess you will have sensitivity, you will not have, where the pain is dull, where it is localized, where it is severe. Everything is important about periodontal abscess, right? Furcation, very important thing. Every time it remains important, from the classification to the management. Hemisection, root resection, which root you resect, what are the types of furcation, what root will have good prognosis, what kind of furcation will have good prognosis. This is important. Cervical enamel projections are very, very important, right? And most critical aspect of management is maintaining plaque free furcation, right? So furcation management and everything surrounding furcation important. Do look for all those questions regarding neighbors probe and the images around furcation. They are important, and do not get confused when it comes to what is root resection and what is hemisection. I still get questions from you people, sir. We can do both in some case, and how can we differentiate? Simple logic you have to apply. Like if it is mandibular molar, then hemisection will be more beneficial or more probable. Or while it is maxillary molar, then you will look for root resection. In maxillary molar, it will be difficult to do hemisection. Okay, so you have to apply your knowledge here. Plaque control in this mechanical, chemical, scaling, root planing, principles of instrumentation, everything is important. Brushing techniques, Bass method, Stillman's, charters, phones, brushing technique. I mean, they remain evergreen question. You would have read them, but they are still important. A new question can be asked. Difference between Bass and modified Bass, Stillman and modified Stillman. We have always discussed. Like when I'm discussing this video, I feel like yes, we have discussed this, but you have to be on your toes because a new question can be asked. So when you study, you look for questions that can be asked in this. Okay, like what is targeted hygiene? What is that quarantine method of full mouth disinfection in 24 hours? What all they do, right? Abrasives in your dentifrice. What is the composition of a toothpaste? Okay, how does it differs from a tooth powder that you have to look for? And then the chemical plaque control, chlorhexidine, everything is important. The taste changes with chlorhexidine, that you cannot forget. What taste changes with chlorhexidine, what side effects chlorhexidine cause, what in the immediate future, and what side effects occur if you use them in a long term. Okay, so all these questions about plaque control are important. Brushing techniques, I already told you. Then what all agents of chemical plaque control can be used, not just chlorhexidine or essential oil. There is triclosan, there is sanguinarine, there are quaternary ammonium compounds, there is sodium benzoate, there are disclosing agents, right? You have to do all of them. Instrumentation, like I was telling you, scaling instruments, curates, all the curates. Okay, I mean subgingival instrument. Difference between universal and Gracie, evergreen question, simple question. But now Gracie 15, 16, Gracie 17, 18. In this you can get confused. Like if you do wrong, like what is 1, 2, 3, 4 is used for and what is Gracie 11 and 12 is used for, then you are in trouble. Okay, that cannot you do mistake in. But these, yes, Gracie 15, 16, 17, 18. Then what is after 5, what is mini 5, what is micro mini 5. Simple difference, subtle difference. But when you go one by one, you will get to know, right? Cross section of the instrument, cross section of a scaler, cross section of a curate, and what is the peculiar point about file, about hoe, about chisel. Every year they can get asked. Anterior sickle, posterior sickle, and the names also. The names might be difficult to remember. It is difficult for me yet, like what is Montana Jack, what are Nevi, all those Columbia curates, everything. But since you are appearing in the exam, so it is important for you people to remember all the names, right? But do not forget Quatine furcation curates, Langer curates, very important. Look for the images which will help you in remembering all those instruments. Shorts, periotivus, I do not know why do they ask it again and again. It's as simple as again, but that question is for everyone, that you can, like, it is not part of the exam because everyone will do it correctly only. Okay, so that you have to do correctly. But all these questions regarding the instruments, principles of instruments, what is adaptation, what is angulation, okay, this you remember for sure. Ultrasonics, in ultrasonics especially, difference between magnetostrictive and piezoelectric. What is the difference in their motion? How many tips are active? Frequency remains the same, 18,000 to 15,000. Sonic 2,000 to 6,500. But where are they contraindicated? Absolutely, where are they contraindicated, and relatively where are they contraindicated, or where you have to use them with caution. That is very important. Sharpening stone, sharpening angle, that you cannot forget. That is again very important. Flushing zone, impact zone, I have used this image to show you that irrigation also, right? Pressure zone, pulsation zone of irrigation devices. Drugs in periodontics, very important. Local drugs delivery, systemic antibiotics, host modulation therapy. What can be the agents for host modulation? What are the targets of host modulation? Okay, that is important. Submicrobial dose of doxycycline. Please do this correctly. Chemically modified tetracyclines. What antibiotics can be used in periodontics? In refractory periodontitis, what works? What is the peculiar thing about ciprofloxacin or clindamycin? Why does minocycline is important, doxycycline is important? In local drug deliveries, how do each local drug gets delivered, right? Atridox, in what form it comes, in what form you have microspheres, what comes in chip form, what is the concentration of chlorhexidine in perio chip. Okay, new questions can be asked, right? Copac, is important. When you have done it, then flaps, suturing of the flaps, what all materials you are using for suturing, what all techniques you are using for suturing. Okay. Gingival recession chapter, very important, ultra important. I believe every year a question will come either in NEET or in INICET, right? The classifications of gingival recession you have to do, the mechanism, how does recession occurs, what are the probable causes of recession you have to do, and then the images surrounding the techniques of gingival augmentation. When you do below the recession, when you do above the recession for root coverage, the difference, how can you increase the width of attached gingiva, how can you deepen the vestibule, which gives you better color matching, which can be used for a single tooth or which can be used for multiple teeth. That has to be done. Okay, everything about Langer method, where do you see creeping reattachment, all the methods, do not get confused with, I mean, you don't have to go when you are revising like this is the complete technique. No, at least remember which technique was given by whom and what is the indication, because we already discussed all these in details. So at this point of time you must remember the separating points, the differential points, thickness of the graft, what happens to a thin graft, what happens to a thick graft. Okay. Flap surgery, everything regarding like from gingivectomy to flap surgery, electrosurgery, what all are the instruments which are used in gingivectomy, which instrument is used for incision in flap surgery, what is used for first incision, what is used for second incision, which is the first incision, what is the difference between marginal incision and a subcrestal incision. Okay, and where will you use apically displaced flap, where papilla preservation flap is indicated, what is the importance of modified Widman flap, why do we call undisplaced flap as reverse bevel gingivectomy. All these are straightforward questions, but you have to do them. Incisions, guys, please, all the incisions, you cannot forget or you cannot get confused in incisions. When will you give a submarginal incision, how much keratinized gingiva has to be there if you are attempting apically displaced flap, what is the advantage of an apically displaced flap, or why will you not do modified Widman if apically displaced flap you are doing. Okay, so flap surgery, each and every point you have to look for. Okay, so these are all the chapters, all the topics that you will be going through when you are approaching your INICET. Okay, all these chapters are important, not just like only these you will go through. You will go through everything that you can revise, and there is lasers also, there is microsurgery, peri-implantitis, a question can be asked every year. But yes, these are the chapters that you will surely go for, and I know you people have studied all through the years, and if even if I haven't told you all these things, you would have done very good in your exam. But we are always there for you. Even now, whenever you have doubts, you can ask us the questions, and I say all the best to you guys. Good luck for your exam.